right, let's just go down the line here and we'll have you guys introduce yourselves. Just a quick introduction.
Sure. So I'm Peter Emmy, founder and CEO for Savoy Life. My background has been in value-based care going back to 2012. I've worked, and I really started getting into special needs and seniors and senior living back in 2017 when I had the privilege to work for a Medicare Advantage plan that really focused on seniors that have special needs. And we had a product that went into senior living facilities, an IE SNP offering, and in that product had about 2,500 lives that we were responsible for. That product was fantastic in many ways, but it also had its flaws. And then from there, I was in delivering primary care on site under ACO REACH to seniors living at home, both in private homes and in senior living. And then it was really through those two formative experiences that led me to create Savoy Life.
Thank you. First of all, these chairs are not great for short people because if I'm sitting here, I have to sit up here on the edge. My name's Kim Elliott, and I'm the Chief Nursing Officer at Brookdale. I've been there for 11 years, and in that time, the last 4 years, I specifically worked on our value-based care model, and we call it our Brookdale Health Plus. We have just under 200 of our communities that will be converted to this model by the end of the year out of our 671 locations. So it's been a privilege to do that and to be here today. So thanks.
Great. Steve?
Yeah, hi, I'm Steve Weisblum, Chief Growth Officer at Centered Care. Been here for, I guess, 3 months already with that amazing team up there in the box. Prior to that, I started a company about 2.5 years ago called Troop Health, which was really designed to bring care management and behavioral health support to communities. The thesis being that this room being the exception, right? But as an industry, senior living is very much a real estate and hospitality business, but residents moving in think they're moving into healthcare facilities, right? So there's a very big gap in care and expectations. So we started a company to bridge that gap with a true tech-enabled services solution, right? Bringing on-site clinical support and technology to streamline care coordination. And then we were acquired by Centered Care, and we merged a few months ago, and we were building similar and very complementary solutions. And yeah, excited to be on this panel and share more about what we're building.
Yeah, great. Appreciate it. All right, so Kim, care management is really a broad term. So as our clinician on the panel, can you start by defining that for us and then speak to how Brookdale has chosen to structure your care management?
Sure. I think if you were to ask people in this room, you're going to get so many different answers because I think care coordination looks different on the health plan side, the provider side, the senior housing side, and they all serve a different purpose. But I mean, basically, it's a comprehensive approach that healthcare takes to manage a chronic condition and a patient or resident with multiple chronic conditions, and that's basically what we have living with us, especially with that age category. So I think that's just one reason why I think care coordination is probably one of the most important panels. I don't know why it's last. Is that Jim's fault? Is that it? Okay, I think it's one of the most important parts of value-based care. You can't have value-based care without it.
Okay, yeah, great. Thank you, Kim. So Peter, can you speak to your care management model and let's say I'm operating a community today where I'm working with 30 different primary care providers. Is this something where I need to narrow this down to a single provider strategy? How do you approach that?
Yeah, no, thanks, Phil. Truthfully, this is really why this is an impossible problem to solve. I mean, there's one-to-many relationship where you have a complex group of residents, let's say 100 residents, and all of the care teams that are attached to them. And increasingly, those residents and their families, they're looking to their senior living partners, the operators, the folks where they've chosen to say, I want to entrust, my care and well-being with this company. They're looking to you to say, how do you deliver on that? And frankly, I think it's kind of an impossible challenge when you put those numbers together. That's a huge number, right? When you have, value-based primary care providers, they're managing a lot of that. They're doing the care management, the care coordination for their patients. But if you're trying to think about how do you organize that system for your entire community, that's something that typically within senior living, we're just not staffed to do that, right? You have a team that is part of the reason I got into this, and actually it was in my last job, was with a health and wellness director who was brought to tears simply because she's a very mission-driven individual. She really wants to deliver the very best for all of her residents, but she couldn't get the responsiveness that she needs from the care teams that were attached to her residents. Like, she couldn't get them to pick up the phone, to answer the call, to give guidance. And she was at this particular day, it was with a particular resident that was like her breaking point, but she was in tears. And what I came to be thinking is, I was like, there's got to be a way in which, like, we've got all these healthcare solutions out there. We're doing amazing things out in healthcare. I've actually had the privilege to be part of those. And yet when I came in and I see this coming through in senior living, none of them are really like designed around making senior living work better. Right. And so how do we design something that actually hooks into what senior living operators need at the ground level and make it work better? And so that was where it's like, okay, well, if we're partnering with the health and wellness director, how can we help them manage all of that chaos? And so because you're unlikely to be able to take all of those 100 residents and get them behind one doctor or one health insurance plan. I've tried to do it. I mean, I was selling a health insurance product. Dan Cornymans knows it well. I was selling it. And, generally speaking, we got our fair share of folks in the community, but we weren't getting 100%. And so if Kim were to turn to me and say, like, well, how are you helping the entire community? I can't. I can only help those that I'm assigned to. And the same goes for the PCP. And so that's why what we do is we provide peer-oriented staffing. So we put a nurse care concierge on site to then work with the existing care teams that are attached to every one of those residents. So the residents get to keep their health insurance. They get to keep their PCP that they may like and value very much. And then we then, as a medical group on the back end, but a nurse on the front end in the community, can actually partner with that health and wellness director and really work, I like to say, the Batman and Robin type of approach. The health and wellness director is Batman. We're just Robin. We're there to, partner with him or her, support their needs, and really solve for a lot of the friction points that exist, in senior living. Because, what you describe, all those different touch points, that's the mud, right? I mean, that's the stuff that causes burnout. Teams that are mission driven, they feel that they can't succeed. And then ultimately that results in turnover. And we all know how the staffing turnover and staffing challenges in this industry are really acute. And so how can we address that? We've got to find solutions that really meet senior living operators where they are, and that's what we do at Savoy.
Great. All right, Steve, let's turn to you. And can you talk to us about what is Centered Care's model, and let's also look at, from a technology perspective, where are we capturing some of this key data to help you make your decisions?
Yeah, no, absolutely. So, I just to kind of double click on something that Kim said, we believe at Centered Care, and I think most of us on this stage and in the room, the care management is the critical, often missing piece, right? That's where all the gaps, like things slip through the cracks. And, I tell a story about my father in his final year. He passed earlier this year, but he had a hell of a year. He was in and out of the hospital. And one Sunday, he was discharged from the hospital. That week, he went to his primary care doc and 3 specialists. All 4 doctors drew blood. By Saturday, he was back in the hospital with a UTI. Like, no communication, it was completely ridiculous. So, we've kind of seen firsthand, really the power of this. So, what we do at Centered Care is we're coming in and we're providing all the care management, the behavioral health support, which is a critical missing piece. But what's unique about our model is effectively we're billing time-based, like Medicare fee-for-service codes. And the way it works today in a lot of communities is the local PCP might already be billing the chronic care management code because that's low-hanging fruit to them, right? And it's revenue. And some of them are providing the service the way it's designed, and others are, from what we've seen, are not. But if you ask the senior living operator, if you ask the staff on site, is this doctor providing CCM? Most of the time they'll say no. Because they have, not only do they have no idea that the doctor is providing all these care management, billing these care management codes, but the community is getting zero value out of it. So what we're doing at Centered Care is most communities have somebody on site that's doing all of this work, right? They're doing all the care management, all the scheduling, all the care coordination, all the communication with families and providers and the filing. So at Centered Care, we could capture that time if they're employed by us, right? And apply it towards these time-based, fee-for-service codes we're billing. So now what we do is we'll partner with the community and we'll employ like maybe a health and wellness coordinator. And what that allows us to do is capture their time, right? They're still going to the same building with the same, role, same residents, same, they're not going to like other Centered Care clients, but they're doing it with a lot more support and a lot more technology, right? They have our, our operations team, our chief medical officer, and all of our tech, at their disposal. And what that does for the operators, a couple of things, right? One, now we're providing these services with a trusted source. So it's a primary care adjacent model, meaning to enroll a resident in our model, they don't have to switch primary care docs. They can keep working with the doctor that they like and the community, has a relationship with. So it's a much easier, call it sale, right, to get patient attribution and penetrate a building. And now it's also being positioned and provided by a trusted source, that wellness coordinator that's, oftentimes been on site for many years, right, and has a relationship with the residents and families. So to give you an example, when we launched in a community a few months ago, we enrolled about, I think, over 80% of the residents in 2 days into our program, right? Because it's, it's just, hey, you get to keep your doctors. We're just coming in on behalf of the community to provide more support and more services. But the benefit to the operator is, right, now because we're employing that person, is we're taking that salary off their books. Because now they're employed by us, and we can monetize them, right, by our fee-for-service revenue. From our point of view, it's like we'll either be paying that person, X dollars per hour or per month or per year, or somebody else we hire to provide those services, right? So it's sort of net for us, but the operator now, that's a direct savings, direct impact on NOI, and it adds to pretty significant, to the asset value of the real estate. So, from a clinical model, that's what we're doing, and it's been working, even better than I think we expected. And we were pretty excited when we launched it. So, do you want me to go into the tech now, or was that?
Yeah, that'd be great.
Yeah. So we're, we at Centered Care, we believe we're a true tech-enabled services company. I mean, we can't have one without the other, at least not today. So we built a data analytics platform that sits on top of all of your point solutions, right? So it sits on top. So, I think the biggest problem from a technology perspective, right, in senior living, but also in healthcare more broadly, is interoperability, right? None of these platforms are communicating with each other. So we built something, we'll sit on top of everything, and we'll integrate with the EHR you're using. We'll integrate with, obviously, with Centered Care and our EHR and our clinical program. We'll integrate with, if there's preferred providers and primary care docs, we'll integrate with them. Any point solutions, like we're partnered with Safely You, RPM companies, we could just ingest all this data into our platform. And now we're leveraging AI on top of that, where we could pull that data on demand for actionable updates, actionable insights on anything we need. Like, as one of the examples I tell is so many amazing point solutions and such incredible technology, but who is acting on it, right? What's happening? So one of them is, I came across connected toilet seats, which I think is incredible, because I told you the story about my dad with UTI, and that was one of 7 he had. So anything that could get out in front of that is great. But they install the toilet seats, and amazing technology. But then what, right? They're sending these notifications to the health and wellness coordinator, or maybe at the end of the day, hey, here's a report of all your residents' toileting patterns. Well, instead that comes to us, right, in real time, and then we're flagging anybody that's got an elevated heart rate. And we can engage either the primary care doc or our own doctor to jump in with an antibiotic. I was, on the prior panel, the physician on the panel said that you sort of, when in doubt, send them out. I used to be in the ambulance business, and that was our bread and butter. We would go to, skilled facilities, and all day long we would love taking people to the emergency room because Medicare paid us about 50% more for an emergency transport. Same vehicle, same staff, same equipment. The destination was an ER. Here, right, we need to get out in front of that and minimize all those. So, how do you change behaviors? And you change it by capturing things in real time and then embedding a real-time clinical response. So that's what we're doing here at Center Care.
Yeah, great. And I think, from Yardy's perspective, this is where we can really make the magic happen. We focused for many years on kind of the day-to-day operations, the day-to-day charting. And this type of the supporting the care collaboration component is where we're very much focused right now. So we're working with a number of the vendors in this room to help solve that problem that you spoke to, Steve, where getting all of this data into one spot, so that your team, both your internal and external team, can make the correct decisions. So.
One thing I would add there is if you think about these two models as they've gone through them, Brookdale did something completely different because there wasn't Savoy Life. There wasn't Centered Care when we were doing our model. So when we started our model, I was a health and wellness director in my previous life, and I know exactly what it's like when that nurse is trying to get everything done at the end of the day, doesn't get it done. So we really looked at the care that our residents were receiving and the gaps in care and the lack of communication between the provider and to the family. And we knew that something more needed to be done. So we created an in-house model. So our care coordination is completely in-house. And then those care coordinators function and coordinate with different provider groups. But what we found there is we found that rather than going at it with a partner, as most people do today, we kind of created it from the ground up and just said, even if we don't have the right provider, partner, or health plan that we're working with, how can we create a clinical model that would give us value-based care outcomes and decrease our hospitalizations? And how can we just prove on our own that we can do this with our model? So it took building that and then the execution of it. But we got to the points where once we said, okay, we can do this, we have got the model that we can create these outcomes, then it was a perfect time to go to those partners and go to the health plans and say, look at our results. So with doing it since 2019, we've got 5 years of data to be able to show what we've been able to do with that. So I think it's so interesting that, new companies are coming up saying, how can we help you if you don't have the ability to create it from the ground up?
Yeah, that's great. Did you want to jump in here, Peter?
Yeah, I was just going to say, it's all about what you're talking about, Kim, is you have healthcare happening in your building. The question is, are you in control of it? Because that healthcare is impacting your KPIs, it's impacting your performance, it's impacting your residents' satisfaction with your product. And so can you harness a program like Health Plus or Centered Care or Savoy Life to take better control that you then own and drive the healthcare within your community, so that then what you can produce, right? Like you're measuring the outcomes of your Health Plus program. You're looking at how it's reducing staff turnover. You're looking at how it's improving length of stay. And those are the same things that, we're after, is like, how do we partner with communities to help them take better control over the healthcare that's already happening in your building and make it actually work better for you?
Yeah. Let's expand on that a little bit. I'm curious on, can we speak to, when we put a coordinated care management strategy into place, let's compare and contrast what a community looks like in terms of resident outcomes before a care coordination program, and also the wellness department. How does this impact the wellness team?
So I can speak specifically to the way that we do it. So the community still runs as it runs. There's a health and wellness director. They are completely responsible 24/7 for the clinical programs within their community. We have an RN care manager that oversees a certain number of residents. Depending on the size of the community, you may have them, within covering 2 communities, covering 3, depending on what the situation is. So they're managing those, that's returns from the hospitalization, anyone with change in condition, that first year that they're with us, trying to get them stabilized. But it really does make a difference, because at first we thought, okay, if we do care coordination on top of what we've got, you're going to have the health and wellness directors in our communities saying, you're stepping on my toes. Why are you coming in? What are you doing? And we saw the exact opposite. They actually tell us now, if I didn't have an RN care manager, I don't know that I could do my job anymore. It really changed the way that I do that, because you have somebody following up those in-depth med reconciliations and following up on the details that a health and wellness director may have a call in on the next shift, and they're spending all of their time trying to cover a shift. So you see a difference on the clinical staff. You see a difference with the families, because the families appreciate that person calling them saying, I see your mom just came back from the hospital. She's had a hard time with this and this. I've already been in contact with the provider group. They came in today. It's just that extra step and that extra layer that makes a difference.
To just add one other element of that, we've also seen the impact from the community care providers. Because ultimately, if you're an operator, you're trying to figure out how do you get more from the community of care providers that are attached to your residents, and how do you get more from them? But they're also looking to you to say, how do I get more from you? How do I get more information, communication? Because primary care is not an easy job. And they are looking for ways to take better care of their patients. And so if you are able to turn on, more information sharing, more communication, primary care providers, I won't say it's universal, but the vast majority of them really appreciate and lean into this. They finally see how they're getting a better partnership model with their caregivers inside senior living.
Real quick, before we break out into audience, there was a question that came in for Kim. When Brookdale made this decision, is the Health Plus model an additional care charge or level up in what the residents pay for?
That's a great question, and no, it's not. That was something that early on we decided not to do. I think that if you look at the rising cost that we're passing along, there's something to be said about what kind of value are you getting for the cost? So for us to say we're increasing the value in your experience because we're doing this. In addition, if you look at it from the provider side or from any type of incentives, why would somebody want to give us incentives on something we're getting paid to do already? So it's very clear this is what we're doing, going above and beyond where we've been able to. And just because it's Brookdale, it's not like I had millions of dollars to go out and try to make this happen. Every dime we spent, I had to be able to show a return the entire time we've been doing this. So that return came from the incentives, from, the different agreements that we've had. And then also just a huge difference in our performance as a company. Our Health Plus communities perform better. We have better NOI. We have better higher move-ins in our Health Plus communities. And then shockingly, we didn't know this, but we ended up with a 20% lower healthcare turnover. So for any associate that's touching the residents, 20% consistently year over year turnover with this program.
All right.
I think we're close to time here, so we're going to move into breakouts. As we were roaming, guys, what caught our attention? What were we talking about out there in the room? Anything that? Yeah, go ahead.
So I was over at table 2, and there's all this data, right? And all the data is coming at you, and so much of it is still just being processed via word of mouth is the first problem, right? It's not all being consolidated and compared against it in relative terms to see what do we need to pay attention to. And then the second challenge is that then, how are we equipped to actually take action on that data? Who's going to do it, right? I mean, we're already challenged as it is. Maybe we're a smaller operator. We don't who can we, it sounds like you're asking to put more bodies, more staff to dedicate to tackling this, this challenge, this opportunity, but also challenge. Where does that come from? And so I think that's, that was the debate that we were having over at table 2.
Kim, yeah.
Yeah, I think it's some of the same stuff. It's like, how do you do this? What is the cost? How do you hire the extra staff? Where does that come from? And I get that. But when I said earlier that it's not like it was a big budget and you've got to go do it. I mean, if you really prove the program just works. It works if you're creating a greater value. And when we do it, it's not like we send out a falls management program and tell everybody just to roll it out. I mean, this is an intentional disruption of the community. We take the community. They have like 6 months of notice that they are going to they're going to transform into a Brookdale Health Plus community. Then we do education. They get all the education of learning fee for service, value-based care, it's to where they're educated. And then by the time it gets there, we get them all in a room all day long. It is a kickoff, and then there is a go live day. So it's like from the minute you are getting ready to kick off this model, it's like we start selling it 3 months in advance. Let me tell you about the model that's coming. So we see a lift in our move-ins right off the bat. We always get that increase. So you really can show that you got operational results. And then in addition with your just your incentives, your PMPMs, it really does cover the expense of it.
One of the things that we talked about at our table was the care management aspect. Sometimes what gets maybe lost is actually making sure that we as operators curate the right partners in the first place, right? That really want to do care management with us. Who are the right rehab people? Who are the right home health people? Who's the right primary care? Because if we don't curate the right people, you're never going to be able to do care management, right? I mean, at the end of the day. And I think that's where we as operators, we've been really slow in that process because we've got, if we get in relationships with 3 home health agencies or 4 hospitals, that's going to help referrals, right? We don't want to, piss off our referral sources and all that sort of thing. But, look at the data, right? You're not getting referrals from those people anyway, right? So at the end of the day, who are the people that we want to be in relationship that really is going to lean in and do good care coordination with us?
Yeah, I think you heard that from Chris yesterday. He was talking about you got to partner with an expert. Right? You need an expert that you can work with that can help you curate that care ecosystem.
That there is alignment, right? That we all want to do this together.
Yeah, one of the big advantages we have with the data that we have access to is, and that we're carefully tracking and measuring, is we're working on a program where we can help our senior living operator partners with sales and marketing, right? Because now we're arming their sales liaisons in the field with real data. So they go to these hospital discharge planners, local primary care docs, any referral source with real hard data. Hey, look at the buildings in the neighborhood, they're real estate companies. We extend length of stay by X number of months longer than them and reduce readmissions by this percent, that percent. Like, this data will help not only keep people there longer, right, and extend length of stay, but also help fill beds, right, and also help with like resident flow on the front end. And then for us, we're capturing them at the point of move-in. So, it's introduced as part of the sales and marketing presentation to a prospective resident and family, and we enroll them on day one. So as the building turns over, we could have 100% of the residents and then full alignment with the model.
I was going to say, I think that's a really important point because I think you hear the concept of value-based care, and I think there's a lot of value-based care happening in a community, but I think what you're hitting on, Steve, is like, how do you transform senior living into a product that is producing a valuable outputs for value-based care at the community level? So it's not just happening inside. You're actually owning, controlling it. You're producing a product that then value-based care entities are, want to partner with, want to buy.
You mentioned something, Kim. I'm curious. When you do programs and things as operators, we talk about having champions, right? You have like 200-ish, right? They're on Health Plus, 400 that are not, right? Do you have those 400 like knocking on your door saying, hey, when is it my turn? When do I get a piece of this Health Plus action? I want to see all these improvements that are happening in those communities.
Absolutely. We get that all the time. Why have you not done this?
Yeah.
And there's just certain states that were not priority states because of either regulatory or California being one. We're not really excited to do anything in California, but yeah, they do. They want to be a part of it now. But there's some. It's interesting. We got to looking at with turnover and how it impacts it, and looking at the data, and we found sometimes that our long-term executive director that's been doing it for 20 years. You think that okay, they've got experience. They know what they're doing. No, feet in the sand. I know what I'm doing. I don't need this. And sometimes it's the person that's been there for 6 months that's eager, wants to do more, and they'll come in and take the model and run with it.
What do we got? Jim?
We had some good conversation here from table 21.
Oh, thank you. So I would say some of the barriers to effective care management is the fragmentation of all these wonderful vendors we have. And so Jim did not pay me to say this, but we are partnering with Centered Care because they do solve that problem. They're integrating all the various tech solutions and from therapy and provider groups and making it into one actionable dashboard. And so I'm thrilled about that. But then the piece that also really excites me is that it's not just creating more work. More data can equal more work for our staff that they don't have time to follow up on. But there's this extra person that is now a full-time employee that is at our building full-time that we're not paying for because they can bill CCM. So to me, it's like a win-win of all the data that we've already invested in, the partners we've already vetted, and it's creating the streamlining in our staff. Like someone said, you can go to one portal instead of all the 17 different logins. So I think that barrier they've found a solve for, and I'm excited to see the results.
All right.
Can I just say, Madison,
Yes.
thank you for your partnership and for the plug. We're thrilled to partner with you. We're super excited.
One thing that I think came up that I heard a little bit is the difference between care coordination and care management. Because I'm pretty sure most operators in the room would say that somewhere on their website, they talk about care coordination as a service that they provide in the community. And, how does that differ from care management? And so I think, one, I'd love to hear a little bit, especially from you, Kim, seeing as how you kind of sit on both sides of this. But this is where finding a partner to do care management is not only going to be advantageous to your residents, to their families, to their teams, but this is going to be a massive differentiator for you because this is going to feel like a much more seamless healthcare oriented service. And it's a way for you to set yourself apart from, the care coordination that is already happening. Because when you start to understand the difference between those two words, coordination and management, it's really tough when you're sitting down with a family and they're like, well, isn't this something that you said you already do? And, by the way, the community right down the street that I just finished a tour with said that they do the same thing. And so I would love to hear the perspective of the panelists on their definition of care coordination versus care management.
So I asked the same questions. Whoever asked it, great job. I asked the same question, and we had our marketing team. We kind of challenged them, and we were able to say, what is the difference? And in this marketing study that they did, they went out and they interviewed care managers and care coordinators from hospital systems, health plans, and all over, and said, explain to me what you do, what your job is. And we call ours RN care managers. Is what we call them, because what we found is care coordination a lot of times was very similar to care navigation. But when you look at our program and what we're doing, it's really, I was telling somebody earlier, if you take side by side of like what a provider group or a health plan and what we do, and you actually list the activities, what they do from the time they get up in the morning to what their day looks like, there's not as much overlap as you think. There's two different functions that they're doing. And the way that we see it is we've got a complex group of people. We've got a lot of families with a lot of questions. And we're more of managing it to where I think on the provider side and on the health plan, it's more of like navigation or coordination. So that's what we call them, care managers.
Yeah. For Peter and for Steve, another kind of nomenclature kind of important thing is, care management is a Part B program that CMS has said that they want to invest in that has CPT codes that you can build toward. Can both of you speak a little bit to the actual care management programs because that's a big umbrella, right? So if I go on CMS website and I type in care management, I'm getting like a lot of different programs. And so can you speak to the programs that you're actually using and implementing in these communities as well?
Sure. So in our communities, we're really pulling on three levers. So chronic care management is the most popular and common one that we use. Those that have 2 or more chronic conditions are generally eligible. And what we're able to do is then we're able to put together a care plan for each resident that's in that program. And that care plan for us is really designed around how do we ensure that this individual can thrive, in senior living with the caregiving supports they have, with their advanced care planning that we complete with them. And then our nurses and resident care coordinators that we put out into the field, they're the ones responsible for executing that care plan and integrating it into every one of the communities that we go into. Additionally to that, different flavors of that would be principal care management and collaborative care management. I think an important call out here, and we actually discussed this a little bit at table 2 earlier, is that if you, in our model, if we encounter a patient, because for us they're patients, because we're a medical group, if we encounter a patient that is already getting chronic care management from their PCP, well, we can't bill chronic care management, full stop. That's the PCP domain. We're offering chronic care management where someone is eligible for it, but not receiving it. Now, that's a separate question as to whether you, the operator, are getting value from that chronic care management being provided by that PCP. I think that was something that we were talking about a bit at the table. But principal care management is a different flavor, focusing on really supposed to focus on a singular condition that landed them in senior living that we're managing to ensure that they can thrive in the setting. So a similar flavor to CCM, different vertical though, if CCM is already being billed for by primary care. The third one, collaborative care management, is a bit of a different program, really focused on those with behavioral health diagnoses. And so we heard the GUIDE panel earlier. It's got a lot of similarities to GUIDE. And what we're really focused on is integrating psychiatric behavioral health care with primary care. And so we're doing that in principally memory care facilities today, but it still is care management of a different flavor, but for a specific population. And so those are the 3 programs that we deploy and that we're able to bill for to provide our services in every one of the communities we operate.
Yeah, and we have a similar model, right? The foundational codes of our clinical model are CCM and COCM, right? Chronic care management and psychiatric collaborative care. We have a psychiatric nurse practitioner on our team, right, that helps with med management, making sure that the resident's on the right medication. And leveraging all of this data, right, in our platform, we now could use AI. It's been trained to develop care plans, right? So we could, based on the codes we're billing and the services that we're providing and billing CMS for, right, we could use real data from primary care, from our care notes, from any specialists, from EHR, and create customized care plans that check all the boxes based on what we need to do to build these codes, but more importantly, the right clinical model and program that the residents need and will help them thrive.
All right, let's give our panelists a big round of applause here, and thank you very much.